Welcome to the first Health and Wellbeing Board of 2021. For the benefit of the public who may be streaming this meeting or watching at a later date, I'm Hal Willison, Executive Portfolio Holder at West Berkshire Council for Public Health and Community Wellbeing, Leisure and Culture, and I'll be chairing this board today. I'll be assisted by Gordon Oliver as clerk for the meeting, James Townsend, who will be taking the minutes, and by Linda Pye, who's the Zoom host. I'll now ask Gordon Oliver to display some reminders about how we conduct meetings via Zoom.
Thank you, Chair. In addition to the points displayed on the screen, if it becomes necessary for members to telephone into the meeting, you will not be able to speak. So once everyone who has raised a Zoom hand has spoken, the chairman will ask anyone who has telephoned in to speak in order. Any voting necessary will be done by a show of physical hands. If we need to adjourn the meeting for any reason, then the chairman will advise the members of the revised time and date of the meeting. If it's a short adjournment, you will be able to rejoin the Zoom meeting. Otherwise, a fresh appointment will be sent. Do members have any questions about how the meeting will be run?
This meeting is scheduled to run until 11:30, but we have a very full agenda, so we might need to extend to 12 o'clock. Could you please try to be as brief and succinct as possible to try and keep the timetable? Thank you. Clark, do we have any apologies?
Yes, we've received apologies from Zahid Aziz from Thames Valley Police, Bal Baya from the CCG, Paul Coe from West Berkshire Council, Charlotte Hall from the Corn Exchange, and Dom Hardy from Royal Berkshire Foundation Trust, and Councillor Dominic Bowick.
Thank you. Moving on to the meetings of the last meeting, which was back in September, so things have changed mightily since then. Any comments or observations on any of the minutes, please? I can't see any hands up. No. Okay. Could I ask the board to review the current? I'm so sorry, I should say I will sign these minutes electronically. Can I invite the board to review the current items in the forward plan and suggest any changes or additions? Just to mention that the workshop plan for February has been cancelled. The April conference is to be postponed until later in the year, probably in September or early October. No, nothing. Okay. Can we move on to actions from the previous meetings then, please?
Sorry, Chair.
Sorry.
With regards to the forward plan, I was looking through this last night, and I think there's some. The leisure strategy is currently on there, and I think that date may need looking at.
It's down for
March.
Will need looking at. Yes, it'll need to. Ooh. Next meeting is May, I think, isn't it, from memory? Just check. Sorry, bear with me just a second. The next meeting is actually May, so we should be all right for that, I'd have thought. Okay, so we can move on to the actions arising. Most of these, I think, have been completed. The only ones outstanding I can see were liaison with the Water.
Chairman, Councillor Vickers has a hand up.
I'm sorry, Councillor Vickers.
Sorry, Chairman. I mean, I got my hand up because maybe it's just me, but my sound keeps coming and going, particularly when you're talking. Is that just my problem? No?
I don't have a problem with that. I can't.
That's just my problem. Okay. Right. Well, I hope I hear everything clearly. If it continues, I don't know. I might turn my video off. I might try and move around a bit, but
it may be worth coming out and back in again.
Sorry.
It may be worth rejoining the meeting. It sometimes improves the connection.
Really? Okay. What, to go out and come back? Okay. All right. Shall I give that?
Give it a try. So just going back, the outstanding points I could see were talking to the Waterman Theatre and Corn Exchange. That is still outstanding. It was down against me. One of the officers is actually dealing with it. And the second one I've got is 153, which is another peer review of the Health and Wellbeing Board. We've agreed with OSMC that this will be delayed until after the COVID crisis is over. And that was it, as far as I'm aware. So could we then move on to declarations of interest, please? None? Those two. And Andrew Sharp and Councillor Vickers.
Chair of the West Berkshire Rapid Response Cars.
Thank you. Councillor Vickers, are you back with us? You're muted, Councillor Vickers.
Yes, I just wanted to declare that I'm a member of the a board member of the Health Watch.
Thank you. Can we therefore move on to public questions? And thank you for the member of the public who has submitted a question today. We've received 8
Chairman,
questions.
you have more. Chairman, I apologise. You have more hands up.
Councillor Masters and Councillor Masters and Councillor Bridgman.
I'm chair of 8 Bells for Mental Health in Newbury.
Okay. And Councillor Bridgman.
I wasn't making a declaration, but I was going to point out, for the benefit of Andrew Sharp, that his declaration is in our standard agenda at 5. I would suggest, obviously, as people bring forward declarations such as the ones we've just had from Councillor Masters and Councillor Vickers, that they're added to that list. It just saves, I think, that really, I know I'm taking up time doing it, but it would hopefully save it in future meetings.
I agree. Thank you for the recommendation. As I said, we've had 8 questions, all of which have been submitted by Paula Saunderson, who's elected to attend the meeting to hear the responses to each of her questions and to ask a supplementary question if she has one. Please note, in accordance with the current process, you will not need to say, I asked the question standing in my name. Instead, your question will appear on screen and will be answered by the relevant board member. You will then be given the opportunity to ask a supplementary question, but this must be only to clarify the response provided and must not introduce any new business. Please note the time given for public questions is limited to 30 minutes, and if your question has not been answered within that time, you will receive a written response within 5 clear working days of the meeting. The responses will also be published on the Council's website. Can we admit Paula, please?
Yeah, Paula is in the room.
Thank you. Public questions are usually answered by members of the board, but in this case, as she has far more knowledge, I would like to ask Shai-Rose Claridge to answer each of the 8 questions. Paula, after each question is answered, you have the right to ask a supplementary question. As I said earlier, this must only be to clarify the response. Shai-Rose.
So, Chair, we've got Nikki Cartwright, who's our Director of Joint Commissioning, who's joined us to respond to the questions because she's our lead director for this portfolio. If that's okay for Nikki to respond.
That's perfect. Thank you.
Thank you.
Nikki, we can't hear you. You're on mute.
Yes, I was on mute. Thank you, Chair. I have a question question 1 that isn't showing on the screen. That's it. Thank you very much. And good morning, Paula. As of January 2021, there are 987 people who have a dementia diagnosis registered with Berkshire West CCG, and that data is taken from a national source.
You have a supplementary to that question?
Can you hear me?
Yes, again.
Sorry, the screen all went blank. No, I have no supplementary, thank you.
Move on to the next one then, please.
Thank you. We are unable to report an answer for this question as the CCG does not capture data for general long-term care needs.
Is there a supplementary to that one, Paula?
No, Paul Cole has provided some information.
Okay. Nikki?
Thank you very much, Chair. The figures that I'm going to give you are for 2019-20, and they're for clients over 65. However, the CCG does not record diagnosis, and we don't hold that information by local authority. So the figures that I'm going to give you are for Berkshire West CCG. So in 2019-20, we had 1,065 people who were in receipt of funded nursing care. We had 188 people who were funded for fast track services in 2019-20, and we had 45 people who were eligible for CHC funding in 2019-20.
Any supplementary, Paula?
No, thank you.
On to the next, please.
The data source used for this answer is Connected Care, and the only confirmed set of information that I've been able to ascertain is that there are 252 people who are care home residents who are registered at West Berkshire West GP practices.
Any supplementary, Paula?
No, thank you.
In West Berkshire, rough data indicates there are 15,000 unpaid carers, not all for people with dementia. GP practices seek to collect information about people with caring responsibilities. However, I can't provide you with the level of detail to answer this question in full. We don't have that detail.
Any supplementary, Paula?
No, thank you.
Both the CCG and the local authority implement the approaches as set out by national government policy and directives.
Any supplementary?
Generally, are you happy with those directives?
I don't think it's for me to comment on government policy in that respect. I don't wish to be unhelpful, but my role is to take that policy and to implement it.
Thank you.
The CCG cannot provide an answer to this question as we don't collect that data. However, what I can say is there is a commissioned pathway for all people who need palliative care and or have end-of-life needs.
Supplementary, Paula?
No, thank you.
And finally?
It would be helpful, Paula, if you could clarify which bodies this refers to, as that question's open to interpretation.
Well, that's the purpose of my question. Because coming new into this area, there are quite a lot of bodies involved, health trusts, clinical commissioning. Okay. So would it, a general answer would be fine, thank you.
So may I, Chair, may I take that away and respond?
Yeah, that would be fine. Thank you very much. Any help that you can give us in understanding, I represent the carers group, so and we're finding it all a bit confusing.
Thank you for all your questions, Paula.
Thank you very much. Have a good meeting.
Thank you.
Bye.
Bye-bye. Moving on to item 7, are there any petitions?
There's no petitions received, Chair.
In that case, we move on to item 8, which is the Royal Berkshire Hospital redevelopment.
We may be running a little early. They were due to join us at 10 o'clock because their chief exec is tied up in a meeting until 10. So I don't know if there's another item that you want to bring forward.
Paul, we could do Tricultural Heritage Strategy, perhaps. Paul James, I see, is here. Is that all right, Paul?
Yes, that's fine. Can you see and hear me? Would
you like to introduce the report?
I will. Just take me slightly by surprise. Let me find it. Thank you, Chairman. So the purpose of the report then is the Council's executive approved the strategy earlier this month. And the strategy itself has 6 strategic themes. And these are developed into actions by the delivery board. And the next thing we need to do, as we've started on this already, is to set up that delivery group. And the reason, just a reminder, we've taken that approach is that it relies heavily on working with people in the cultural and heritage sector to work together to develop appropriate actions that are doable, achievable, and can be resourced. So we started on that process now, setting up the that delivery group. That delivery group will report here and also to an internal culture and leisure programme board whenever required. So I think what's important from a health and Wellbeing point of view is the whole strategy, but I'm sure you'll have noticed that, and I came to talk to you in 2019 before COVID-19 came along about as we were developing with stakeholders what the themes were likely to be. And so there's, from the beginning, there's always been from all the stakeholders a strong push to have to contribute to the improvement in the health and well-being of all our residents. Nationally, as I'm sure you're aware, Arts Council and Historic England have very much moved towards the health and wellbeing agenda, and that's reflected in their own strategies. So this feels absolutely right, and it broadens out, I think, the benefits of culture and heritage for all. I think I'll pause there and take any questions, unless you want me to explain anything further.
I have Councillor Bridgman, followed by Councillor Vickers.
Thank you, Chairman. If you'll bear with me, what I'm going to do is work my way down some bits I've highlighted in the electronic version that's on my screen, just to highlight some issues I have. I have no issues with the thrust of the report. I have no issues with us joining in. I have some issues with some of the wording of the suggestions, so let me just explain why. It is absolutely correct at 1.1 that the executive approved the strategy on the 14th of Jan, and that the action that is shown at 1.1 and the bullet is part of what the was agreed. The other bit that was agreed was to approve the strategy. And as you can see, what that says is that the executive agreed to set up the delivery group and at bullet sort of sub 3 to report on for that delivery group to report on progress to health and report on progress to, amongst others, the Health and Wellbeing Board. At 3.1, this report says that the Health and Wellbeing Board can help by approving the plan to satisfy the governance arrangements agreed by the Council's executive. Well, the Council's executive has approved the strategy. The strategy includes the plan and the delivery and sets out who is in the delivery group. So I don't think, for us not to go along with the suggestion at 3.1 would fly in the face of what the executive's already done. So I have a difficulty with the precise wording of 3.1. If I just work down until I find more highlighting, so bear with me, this is quite a long report. At 5.6, it talks about the way in which the delivery group is going to be set up, and that it says the Cultural Heritage Strategy Project Board proposes that the membership of the delivery group shall be as follows, and then there's a list, and included in that list down the bottom, one representative of the town councils, possibly on an annual rotation, one representative of parish councils, possibly on an annual rotation, or senior WBC officer responsible for liaison with parish councils. Well, if you go to the actual health and wellbeing strategy, which, as I've just said, has already been approved by the executive, at Appendix 1, it sets out what the Cultural Heritage Delivery Group will be and explicitly lists the partners or members. And it doesn't say, for example, one representative town councils on an annual basis. It simply says one representative councils. It says one representative parish councils, doesn't add on an annual basis. And it certainly doesn't add an or senior officer responsible for liaison. So the wording in this report clashes to a very small extent, but nevertheless, I think to an important extent, with what the executive has already agreed. Options for consideration at 6. The option for, firstly, I suggest these aren't options for consideration. They're actually the alternative options for consideration. And the first one is, well, the start of that says, to not develop a cultural strategy for the district. Well, a cultural strategy for the district has already been adopted by the executive. So the Health and Wellbeing Board can't say, well, we're not going to. It's just an impossibility. And at 7.3, it says, to note detailed delivery action plan will come to the Health Wellbeing Board and the Council's executive for agreement. Well, No, what the executive, as is listed at the top of this report, has agreed is that the delivery plan, actions on the delivery plan, will come to the Health and Wellbeing Board to be. I don't think it actually mentions the Health and Wellbeing Board. What the executive agreed was it will come to the executive within 6 months. Now, there's nothing wrong with it being reported to the progress on the Health and Wellbeing Board, and indeed I've just turned up the executive agenda. What the executive agreed was that the plan would come to the executive within 6 months, and progress would be reported to Health and Wellbeing and the Culture and Leisure Programme Board. So there are tensions between what is in this report and what is actually in what has already been agreed by the executive. And I simply, as I say, I have no problem with what the executive has agreed. Essentially, Health and Wellbeing Board will be part of the delivery group, and that the delivery group will report to the Health and Wellbeing. No problem with that at all. It's just the way in which it's phrased in the report. Thank you, Chairman.
Yep. Councillor Vickers.
Thank you, Chair. Yeah, well, my comments are more general. Obviously, this has been brought to us because culture is considered to be crucial to our health and well-being, which I think we're all realising now. Yes, it's a lot of proposals and fine words, and I see, the top of the list in the consultation is that access and sustainability in our culture is important. And I think we all know that, obviously I speak for Newbury here, but our Corn Exchange is the centre of culture in Newbury, and it's becoming more and more dependent on charitable donations, and that's not sustainable. So I hope that, that we're looking at proper funding for our culture here, and particularly for anything that's supporting sourcing children. Because with what's been going on at the moment, obviously a lot of this is COVID related. Children are going to need more and more outlets to heal their damage to mental health going forward. So I hope all that will be taken into consideration. The importance of culture and entertainment and art in schools, and accessibility to it in healing the population, and particularly young people going forward.
Andrew Sharp.
Thank you, Mr. Chair. A couple of quick points. On Councillor Bridgman's point, I'm sort of in agreement with him. The only thing I'd like to suggest is that wording's changed to support, because although the exec have agreed it, I suppose what we're sort of saying in bringing it here is there's a huge importance of health and wellbeing in how we do this sort of thing. And actually, I suppose what we're hoping for is that the Health and Wellbeing Board agrees this is generally a good thing, or equally, if it was something they felt was a really bad thing, they'd say we don't support it. So I just wonder if that's an option. Secondly, the second point I want to underline that we probably need to ask to see if there's anything that could be drawn into it is the importance of the cultural strategy in terms of both the pandemic and also the treatment of long COVID conditions. It was only this morning on the radio they were talking about the English National Opera helping with people with respiratory issues. And I think one of the key aspects of bringing this to a Health and Wellbeing Board, start to consider the non-medical interventions that should be looked at, should be supported in the same way. If it was a drug, we'd of course go, let's fund it. Well, I think one of the key things in this, bringing this to this board and why it's so important, is that we do also consider alternatives to just medical interventions and drug interventions. Thanks.
Any other questions or observations? Gary Poulsen.
Thank you, Chairman. Thanks very much indeed. I'm inclined to agree with comments that Councillor Vickers made earlier on in terms of investment. I think although I would disagree slightly in this, the Corn Exchange is but one very important facet of our arts offer. The voluntary sector arts community is enormous, and it does play a substantial part in the life of West Berkshire in myriad of ways, operatic groups and theatre groups and so on and so forth, and there are many, and there is also this the arts and crafts as well, which and we all agree that these things play very well into the health and well-being agenda. So I support the report. I think we should be looking towards some investment. There used to be an full-time arts officer, or I think, or at least half-time arts officer. But I think working with the voluntary sector, and if we want the voluntary sector to play into our agenda in its fullest extent, then there needs to be sometimes little pots of money for them to be able to enable them to do that. Now, we're fortunate that we have Greenham Trust and so forth to help, but sometimes I think the authority would need to step up and say, well, we'll match fund things and so on and so forth. So I think that's really, I think Paul and his team would need to go forward with an offer to the voluntary sector, voluntary sector arts community to say, we can help you with seed funding and so forth for various initiatives. Actually, as I've been sitting here, I've just had an email from a brand new vocal arts voluntary sector organisation wanting to further their reach, based in Newbury as well. So it is very much a live thing.
Thank you. I can't see any other hands up. So I think the purpose is just to note this report with Councillor Bridgman's suggested alterations. And then we'll take it to the working party after that. So can we move on then? I gather that...
I put my hand up just to come in on that.
Right.
I think what we should be doing, and I thank you for the comments on what I said. I think what we should be doing is to note the report, note the plan, agree to participate in the delivery group. I mean, in a sense, that's countering what I've already said. I mean, we're sort of already part of it according to the executive, but I think we should engage, absolutely engage. And so far as because according to the report itself, I think we are the lead organisation. What the report says is that the Cultural Heritage Delivery Group will report to Health and Wellbeing, who will have oversight of the work of the group. So I think that there we have a role to play in deciding who the partners and members of the group are. I mean, they're listed in the report as identities, but only a couple of them are obvious. For example, you are listed as chairman of the group, and because of your portfolio, and the Heritage Champion is listed. But so far as representatives of the various arts venues, heritage organisations, economy, tourism, so on and so forth, I think we need to take the role in identifying those individuals. There are a couple of proposals at 5.6, for example, Chair of West Berkshire Heritage Forum for Heritage, Director of West Berkshire Volunteer Centre for Community Organisations. And I think we should agree that. And I think we should look to the delivery group to identify the other members in order to get the delivery group up and running.
In order to gain some momentum and keep this board informed, it might be a good idea, I suppose, if we had an interim report from the July meeting from the delivery board as to what progress they've made.
Well, but it's got to get going, hasn't it? The delivery group has got to get on and meet, and we've got to identify who is going to be on that group. And some of them are at the moment simply representatives of particular groups. For example, representative for economy and tourism. My question, I guess this is a question to officers, is how they think that is going to happen, how they think that representative is going to be identified in order to get the group moving.
Paul?
Yes, we have had that's an extremely good point, and I think we have had discussions about it, and it's been in reports before that. Let's take the arts as an example. Is that the arts community are best placed to look at, if you like, a pack that has what's the purpose of this board, what's expected of members, a kind of person specification, job description, and that the sector are best placed to then decide who is the best person to represent them. And I thought that sort of principle tends to work quite well with strategic partnership working. So I would propose that that they're given information, they can have a discussion amongst themselves, and then come back with a proposal, because it has to be doable for them as well. You know, everybody's busy, and you want people who can help deliver this and who are engaged, but also well networked with their particular group within the broader sphere of cultural heritage.
I still think to keep momentum going, we ought to look at least an interim report back to this board for the July meeting. If only to say these are the members that have been agreed, and this is the programme that we're intending. Councillor Jones.
Yes, I agree, Chair. I think we do need to keep an eye on this. Funding has been mentioned, and that's quite right. None of this will improve without an element of funding. But I think the report very clearly states that part of the objectives of the delivery plan will be to work together between the council and the arts partners, cultural partners, to seek external funding as a partnership, and strengthen those requests for external funding. The council won't be able to do everything that's necessary, but they can work together. So I think that is covered by the report, but this board can do a useful job in overseeing the delivery group and the delivery plan to make sure that actually happens.
Thank you. We've got some background noise coming from somewhere. Oh, it's gone. Good. I'd therefore like to move on to the next item, and I think our friends from the Royal Berkshire Hospital are ready to be admitted.
I think most of them are here, so we can probably make a start. Stephen, would you be able to make John Underwood a co-host so he can present the screen? Thank you.
I understand the members are John Underwood, who's the comms and engagement lead, Nikki Lloyd is the chief executive, Andrew Statham is the director of strategy and transformation, and Sally Moore, who's the head of communications.
Hello, Chair. Good morning, colleagues. It's Nikki Lloyd speaking. I am the acting chief executive at the Royal Berkshire, and I'd like to thank you so much for inviting us to join you this morning. We are, as you can imagine, busy at the moment. We wanted to join you today. We're specifically here to talk about the site redevelopment, which we're really excited about, and the potential for that and the impact for us as an anchor institution and for colleagues in communities we serve. I'm here today with Andy Statham, who's our Director of Strategy and Transformation and Partnerships, and also John Underwood, who's been assisting us from Freshwater Communications with our engagement work. Before I do start, though, I do want to just formally go on record to thank local authority colleagues and our stakeholder colleagues for your help and support. I think the pandemic, for both first wave and second wave, has made us all realise how so important it is for us to all work very close together, and you know, the communities we collectively serve need us to be doing that. So the work that's going on in terms of getting patients home as quickly as possible, spreading the public health messages around hands, face, space, and enabling folks to stop the spread of the infection, the mobilisation of the vaccine centres, and the rollout of the lateral flow tests for colleagues as well. All of those things are helping us see the reduced rate of community occurrences at the moment, the reduced rate of hospital occurrences, and we're hoping that that continues, because the hospital, as you know, and allied services have just been very, very busy in recent weeks. So I just wanted to thank everyone who's been involved in mobilising all of the superhuman things that you guys have been doing as well, and working with us and supporting our staff to make sure we do the best we can for the patients that we serve. The site redevelopment work is something we've been working on over a year actually, fully engaging with our local communities as you'd expect, and we presented our strategic outline case to the board in December, and we've formally submitted it to our regional finance colleagues at NHS England on the 21st of December. We're one of 40 hospitals outlined for redevelopment in the HIT2 programme, which was announced in October. So we're really keenly and closely working with colleagues at the centre to help progress to the next stage, which is the outline business case and then the full business case, so that we can bring the plans to fruition. I'm going to hand over to my colleague John Underwood, who's going to take us through a short slide deck, and then Andy and I are happy to answer any questions that you may have regarding the content or the site redevelopment itself. So if colleagues are happy to do that, Chair, I'd like to invite John to share his screen and to run through the presentation that we've prepared.
Thank you very much.
Thank you very much indeed, Nikki, and thank you, Councillor Wollaston, as well. If I try and share my screen now, just give me one moment and I'll endeavour to do that. I'm hoping that will have shared my screen. Can I just double check with everybody that everyone can see it? Okay, fine, very good.
It has, but you're also showing all the other slides, so you really want to go into full screen if you can.
I find when I do that, it does something wrong on my screen. So let me just minimize that a little, or see if I can just increase the size slightly. Is that slightly better?
Slightly worse than that. You lost the bottom bit now.
Okay, in which case I'll nudge back again. Hang on, there we are. I think on my screen that's about as good as I can get it. Chairman, I've reduced this slide deck to just 8 slides, and I'll be very quick if I may, because I know you've got a very full agenda. As Nikki was saying, the Royal Berkshire Trust is able to proceed with this project because of the government, the fact that the government launched its Health Infrastructure Plan, or HIP as it's known, just over a year ago. And this provides capital funding for new hospital projects over the course of the next 10 years. And our trust is one of just 21 trusts across the country that received seed funding to develop its thinking about new and refurbished hospital facilities. And phase 1 of that project was obviously to develop a strategic outline case, as Nikki was saying a few moments ago, which just before Christmas was delivered to the government, to our regulators, to the Treasury and so on. And this strategic outline case identifies a number of options or scenarios for future development. And as part of our ongoing kind of engagement program, what we wanted to do was to take the opportunity to share this with the Health and Wellbeing Board, as we are doing with the other local authorities in our area and so on. We do believe this is a major opportunity for the NHS and for our local communities, both to improve services, to improve the experience of patients, to improve the environment, and to support our local economy. And our case for change here is based on these 5 C's. First of all, it's about the condition of the hospital buildings, which are suboptimal, and this does result in less than perfect patient experience, poorer working conditions for our staff, high maintenance costs, safety risks too. It's also about capacity. The hospital is currently operating beyond its planned capacity, and expected local population growth and so on will only mean greater health needs and rising demand for services in the future. There's also a question of capability as well. The existing buildings were very much designed to support a 19th and 20th century model of clinical care, and this limits the capability of our staff to provide high quality modern healthcare for our local communities. And finally, there are these 2 elements, climate and catalyst. The environment in which we're currently operating as a hospital, as I said before, is less than perfect, but our buildings actually contribute to the climate emergency rather than helping to reduce it. And we really need a green, low carbon hospital and hospital facilities in order to do that. And finally, we want to be, the trust wants to be something, a trust which contributes to the local economy. Obviously, delivering high quality healthcare is our first objective, but we think we can be a catalyst to help the develop the local economy as well, and that's what we want to do in this context. So, Chairman, let me move on, if I may, to the possible scenarios that we've identified so far. There are 6 of them. The first 2 options are unambitious. They are the option to do nothing, which means we would only simply address the most high risk backlog maintenance issues that we currently face. And the second one is to do the minimum, which is to address more of the backlog issues, but it still, as an option, doesn't take us very far forward. These 2 options are included as benchmarks. They are theoretical options. They're included because we are required to include them as options against which we can measure the other more exciting options. So I won't linger on them more than to say options 1 and 2 are do nothing and do minimum, and they're not the options that we wish to take forward in any shape, manner or form. Option 3, which is the top diagram here, essentially involves the building of a new emergency block. That would be in the center of the current site. It would involve an expanded A&E unit, a new intensive care unit, new operating theatres, and this would help us to separate emergency and planned care, which is widely regarded as being a good thing in the healthcare context and something which the NHS long-term plan calls for. But option 3 doesn't really fully meet the requirements of future demand. Option 4, however, builds on option 3 and adds a new elective care block, a new women's and children's facility, and it has the potential as well for a medical school, and overall it offers the opportunity to really grow our services and to do rather more. The final 2 scenarios that we've developed are option 5, which again is at the top here, which essentially involves the creation of a substantially new hospital with some refurbishment, but the vast majority of the buildings would be new. But this would be on the current site in Reading, and it would be a gradual approach, a step-by-step approach, as it were, to decanting and then rebuilding piece by piece throughout the hospital, as it were. This supports a growing demand. It involves a much greater integration of health and social care. It includes a medical school on this site, as well as the possibility of good research facilities and so on and so forth. And then the final option, which is the one at the bottom here, involves the building of a completely new hospital on a new different site. I should point out that no new site has yet been selected, but this option would offer the opportunity to address all of our local long-term needs, and it would provide a blank canvas, in a sense, on which we could create a modern zero carbon health facility. Now, of course, all of these options involve considerations of cost, convenience, local disruption, and judgments on which would offer, in a sense, the greatest economic benefit. And that's really the subject of our next piece of work. As Nikki was saying a few moments ago, just before Christmas, we submitted our initial strategic outline case. We're now continuing engagement with our local stakeholders, including obviously local authorities, patients, staff, community groups, and so on. And our next step is to develop the options further through an outline business case in the first instance, and then moving on to a full business case with the intention of persuading the government to give us the capital funding we need. And in conclusion, or by conclusion, I would say, if you wish to know more, members of the public, or indeed members of this committee wish to know more, I'd urge you to visit our engagement microsite, which you can access through the Trust website at royalberkshire.nhs.uk. and you then click on the Building Berkshire Together button. Almost 6,000 people have visited this site to date. It's regularly updated. You can find more information there, and it's also a place where you can give us your views as well. Chairman, through you, I'll conclude at this point and hand back to you and to Nikki. And I know that Nikki and Andrew would be very happy to take any questions that people may have. I will also endeavour to unshare my screen.
You're doing that. Can I kick off the questions? In terms of the existing site, what sort of time frame are the various options they're going to take up? And how much disruption will it cause to your normal medical work?
So I can start by answering that. I know Andy is on the call as well. So we, as you know, as a provider of services, we have to ensure continuity of services, whatever is happening. So we haven't stated it explicitly, but at any time, whether we're developing the current site or whether we were looking at an alternative location, we have to continue to operate all of our services. So a part of the planning and the design around the redevelopment has that as a golden thread running through it. So there would be inevitably disruption with builders. We've got disruption on site at the moment. We're de-steaming the site. We are doing, I don't know how many different roof works. We've got a huge amount of electrical work going on, and we're reforming our ED at the moment. So we have constantly site disruption on, and we continue to run the services. So that the planning and the design around phasing of buildings and redevelopment will take into account that need to keep services running and safe traffic in and off site for suppliers and patients and staff at all times. So that's within the assumptions of what we're working on. I'm just going to bring Andy to talk through the timeline. As you know, we've completed the strategic outline case. So the next steps are the outline business case and the full business case, and then obviously planning and spades in the ground. So Andy?
Yeah, so I think that the question on timing really depends a lot on how the national programme plays out, along with the financing from Treasury. We are one of the second wave health infrastructure programme trusts, and the government is signalling that it expects most of our expenditure to lie outside of this financial settlement, which runs up to about 2024. So the kind of principal works that we're expecting at the moment, although we had a really positive meeting with the national programme yesterday, so things could move around, but we were expecting the principal works to start around 2024 and then move on from there. So the timing is a few years' time, which gives us sufficient time to plan that move around in order that we can maintain the full operation of our services if we chose to stay on the current site.
Sorry. I have Councillor Vickers, then Gary Poulsen, and then Councillor Doherty.
Thank you, Chair. Thank you for that interesting presentation. I mean, like everybody, most of us have probably visited Royal Berks, possibly relatively recently, and it's wonderful.
You just muted yourself, Councillor Vickers.
Sorry, I did, but it sort of muted me again. Sorry. I'm just saying thank you for the presentation, and I think most of us accept that, all of us probably, that the dire need of the Royal Berks for some redevelopment. Wonderful staff, but struggling with a building that's really, really dreadfully out of date with lots of little prefab bits at the back. I suppose a totally new build, not only would it give you a lot of scope, it would also mean you're not upsetting what's going on your present site. It gives you scope for sort of, keeping services running more smoothly. I wondered what feedback you got so far from your consultation and what the public is saying coming forward, whether that's, or is that too early? And also obviously looking, if you do have a new site, looking at accessibility. Obviously us over here are thinking, at the moment, you're reasonably accessible by public transport, but possibly could be better. So looking at accessibility and whether, whatever you do, you might have some special arrangements as regard public transport, some special buses, some, you know, whether that is something, obviously, depending on what your decision is, something you might be looking at in the future, so that, you know, people, whatever their conditions, even if they're quite vulnerable and immobile, could actually get picked up from somewhere central and not have long journeys in their car. So that's a thought.
Thank you, Councillor. Really good questions. I guess if I can pick up the transport and travel aspect of it, one of the things we're already working on with our site, you know, we're really conscious as an anchor institution that we have a responsibility to be a good neighbour. So one of the things we're looking at is how can we increase public transport and accessibility for the site. We've commissioned a report from an organisation called Access Able to review all of the access into the buildings and to the site so that it's easy for folks to get to us, and once they arrive to navigate their way through the buildings. We have our CCG fund transport for vulnerable people to reach site. So if folks aren't able to get there on their own and they're vulnerable, then there is funding to enable that to happen already. Clearly, one of the things we've learned through the pandemic as well is the need to review public transport. So we have a number of bus routes, and we have bus services, several bus routes that come right past our front door from various locations. And we're always looking to see what else we can do to extend those and reduce the number of vehicles coming into the vicinity, and obviously the parking issues around that. Any site we look at, and the strategic outline case which we've just submitted has to give a range of options. So at this stage we're not required, and indeed it would not be appropriate for us to say this is the option we want to go through. The SOC requires us to look at a range of options, and then the next stage, the outline business case, is where we would refine those options and come up with a preferred option for the full business case. So absolutely the disruption would be less if we were creating a greenfield site and could move wholesale, as has happened in other parts of the country. Quite clearly, as well as disruption, we also have to weigh in cost, and the cost of an entire new build is significantly in excess of some of the refurbishment options. So depending on the envelope of funding available, that would determine, help us in the decision making around which option will be the preferred option within the envelope of funding that we have. So yes, a greenfield site will enable that to happen more straightforwardly from a disruption point of view, but that is one of the considerations, not the only consideration.
Thank you. Gary Paulson.
Thank you, Chairman. Yeah, I think Nick is right to cover my point, really. I suppose simplistically, I know you'll be guided by your consultations, but what's your preferred option? You know, and what would the time frame be for that?
We've put forward in our SOC that we would like approval to further work up options 4, 5 and 6. John, I don't know whether perhaps you could reshare your screen for a moment, just so we can look at those once more. They're the substantial improvement to what we have at the moment. The first options we looked at, which were primarily a do minimum. You'll all have seen business cases for every walk of life that you may have had, that have to look at that whole spectrum of completely entirely replace or do something in between. So the scenarios that we're looking at, so John's I think put on our screen. The scenario of a significant site redevelopment, which you can see on the screen, is that we've got option 4. Option 5 is an even more significant redevelopment of what's on screen and of what's on site, so even more refurbished, rebuilt. And then, I mean, we haven't got an image yet because we haven't done the detailed drawings. We haven't identified a site yet where we could do that. We've looked at a number of possibilities in that frame, but option 6, which is the greenfield site, obviously we need to work out what that would be, what land that would go on, and what form that would take. So those are the 3 options we've put forward as our preferred options following our board meeting in December.
Sorry, I can't see if there's any other hands up at the moment.
Councillor Wollaston, I was going to come in next.
Thank you, Councillor Doherty.
Actually, you've already covered some of the questions I was going to ask Nikki around which options you're going to be putting forward. Within the paper that we've got, we're being asked to seek our views. How is it the West Berkshire Health and Wellbeing Board can assist you? What is it you actually need from us today?
I'm going to bring John in because John's very familiar with all of our routes for engagement and involvement. I mean, we have a total commitment. We want this to be a hospital for our communities, and we've already had letters of support from colleagues which have really helped our case, and we want to continue the dialogue. But John, if I can bring you in just to explain the steps we're taking over the coming weeks and months to keep that engagement going.
Yes, of course, Nikki. Thank you, Councillor Doherty. I think the crucial thing is that we've just ended phase 1, which was of the engagement process, which was linked very much with the development of the strategic outline case. What we anticipate is that as we move forward into developing the OBC, there are a couple of things. First of all, we'll be continuing with very much the online engagement that we've been undertaking at the moment. That's partly because of the COVID crisis. So inevitably, you know, the restrictions restrict us from having face-to-face meetings and so on. But we are managing to do, so we have done a significant number of online focus group discussions. Indeed, 1 or 2 people on this call have actually been involved in some of those. So they've been very successful and been very helpful in terms of developing our thinking and so on. So we would certainly continue with those. The microsite that I mentioned earlier on has both a survey and an open forum for discussion. So we'll certainly be continuing with that. But in addition, we've also been having, we've got an advisory group, an engagement advisory group. And of course, we're making big efforts to come round to health overview and scrutiny committees, health and wellbeing boards, and a myriad of meetings with the voluntary sector, the third sector, and the business sector as well, and with a wide array of different organisations. I think the purpose of this particular presentation was, it was almost as it were a courtesy moment, having delivered the strategic outline case just before Christmas. It felt that this was an appropriate moment to come and share with the members of this committee those scenarios that Nikki has been talking about and that I ran through in the presentation. But the commitment, I know in Nikki's mind and much more widely within the Trust, the commitment to ongoing engagement with our stakeholders, with our staff, with our local communities is complete and unequivocal.
Okay, thank you.
I've got Councillor Bridgman, then Matt Pearce.
Yes, thank you, Chairman. I would like to assure Nikki and colleagues that we have engaged with the getting the message out. As you'll know, I'm a governor at Royal Berks, and I've probably seen this presentation a number of times now. But I was going to say 2 things about it, but before I get on to the point I was going to make, I certainly engaged with our comms team back in August, and we pushed out the engagement message, and hopefully that reached a number of West Berkshire residents, and they then engaged with the microsite and so on and so forth. We certainly pushed those messages out through various.
I did. Thank you very much. Thank you.
But it's not a question. I just wanted not really confirmation, because I think I know the answer, but I just wanted, for colleagues' benefit, to just establish that in all of your scenario, well, sorry, in the new green build scenario, one of the factors within that is, of course, the value of the existing site. Because there is an offset, and it may turn out that that is still way more expensive than the other options. Until you crunch the numbers fully, we won't know. But just to make that point, that obviously one of the benefits, if one can put it like that, of a new build is perhaps still retaining a presence in the centre of some kind, and maybe splitting operations between the two, greenfield and the existing site, but certainly liberating some of that site for other purposes, and the money involved would come in on the number crunching. Thank you, Jim.
Yeah, that's exactly right.
Matt Pearce.
Thanks, Chair, and thanks, Nikki and colleagues. It's just a very quick one, Nikki. I think it's just a note. I think myself met with Steve McManus probably a year ago and Andy, and I was just wondering, it's probably too early to have this conversation, but again, just making sure we kind of think of the NHS as the anchor institutions, how we can do placemaking, enhanced health behaviours rather than just treating illness. So how we can kind of maximise whatever the solution is in terms of those public health benefits, in terms of prevention and sustainability. And I'm sure that's in your plans, but I'd welcome ongoing public health input to help you and support those plans going forward.
Absolutely. I mean, you know, the sustainability element in its broadest context. So keeping our communities as well as possible for as long as possible, empowering folks to take control of their own health and making sure information's available. That means that we're all able to live as long as and healthy lives as possible, and for the health services to be here to help steer folks when required, or intervene when required, when we're here when you need us. I think you'll know maybe that some of the developments we've been doing before even the site redevelopment around our service evolution, we have thousands of patients who are currently on remote monitoring, which sounds a bit odd, but actually what that means is, so if you've got a long-term condition like multiple sclerosis or HIV or gastroenterology conditions, then in the old ways, you would have been called back to outpatients come what may every 6 months or whenever, and have a check and be told you're okay or you're not okay or whatever. We now, using remote monitoring, have say thousands of patients on our database who are taking regular checks, blood tests, etc. And provided those are within normal tolerances, then they're fine. If there are any changes to those long-term conditions or patient reports that they don't feel as they normally do, we've got the ability to whisk patients in sort of same day and get an urgent intervention. So it's empowering patients to live their normal lives for as long as possible, and with as little intervention as we need to. And that whole approach of empowering population to stay fit and well is underpinning all of our design objectives in the wider sustainability agenda. So yes, we absolutely want to stay very, very closely in touch with public health throughout. And I think your offer to do that is hugely welcome. So thank you. And as John said, we're obviously got a whole range of ways of staying engaged, and special focus groups and the micro site, and we're going to be running regular meetings like this and hopefully face-to-face at some point, as we explore the further detail of the design in the next stages. So the 1 to 50 drawings, etc., the layouts and the buildings. We want the buildings to be conducive for our staff to stay fit and well working in them, and for the community to be able to use them also. So expect a lot of attention to zero carbon and a lot of attention to the wellbeing agenda to prevent ill health in the first place.
Great, thank you.
I've got Andrew Sharp.
Hi, Nikki. Thanks for the presentation, and John and Andy as well. I think my question sort of relates to a little bit of where we are and the impact that's going to have on future business modelling of what's the appropriate solution, because HSJ, the Health Service Journal, very worryingly said that some of the hospitals under the most pressure currently are now getting to the point where they're so busy with COVID patients, it's really difficult to separate hot and cold. and yet we were in the middle of a business process of putting in a case in that was sort of from previous pandemic in terms of modelling and things like this. Is there any indication that the Treasury is going to look at the importance of additional space in terms of what the final solutions are, the ability to genuinely have hot and cold, multiple entrances, so that if and when any of the conditions or problems we've had this time come again, you know, you're not shoehorning things or closing departments or moving to, you know, private hospitals because the actual site itself can flex, deal with and huge thanks to obviously all the team, the staff who are dealing with this crisis.
Thank you. Andy, would you answer this one? I know it is absolutely intrinsic in our design, isn't it?
I think what I'd say, Andrew, is that yesterday the meeting we had with the central team said that they were very keen to produce a standard set of assumptions around number of single, proportion of single rooms, expected length of stays, size of, various sizing requirements for the new build programme, in part so that, people aren't reinventing the wheel and, taking a lot of clinical time out to think about the same thing when they could do it once, but also because they're very keen that the NHS moves towards more of a blueprint model where you can expect that that's what you've got to be able to work with. So I would expect to see that kind of set of assumptions come through the national programme, which will help us a lot in determining, where we should be. I think that the real challenge is, though, that the real question that I've got personally about that is how do you then translate that? That's easy when you're thinking about a brand new hospital building, but when you're talking about fitting that around the existing site, if that's the option that we choose for, that will create some complexities that we'll need to work through. More positively, I think it will address some of the challenges that we have here in Berkshire. So we're one of the lowest. The Thames Valley as a whole is one of the lowest bedded per head areas of the country in terms of NHS capacity, that's similarly the case around some of the critical care beds and respiratory beds that we've got, and that's already baked in some of our assumptions, is that those are areas that our population will continue to need more of as we age and as the long-term conditions challenge that's been facing the country kind of comes through. But I'd expect to see that as something we'll start to see more capacity requirements for coming out of the national assumptions as well.
Thank you. I don't see any more hands up. So can I thank you, Nikki, for your team for the presentation. We're very keen to be involved and to see how you progress, and wish you well.
Thank you so much, Chair, and thank you, colleagues, for inviting us today. We'll absolutely stay in touch and look forward to updating you as this progresses. Thank you again for all your support.
The next item on the agenda is the Alzheimer's Society report. So can we get Laura and Keelan into the room? Laura and Keelan, welcome, if you can hear me.
Yes, good morning, everyone.
Good morning. And we'll hand over to you to present your report.
Yeah, thank you. So, yeah, I'm Laura Vicinanza and I'm the Regional Public Affairs and Campaigns Officer for the South of England at Alzheimer's Society. And here with me today is also Keelan Erblaster, who is our Policy Officer, and is also one of the authors of the reports I will be presenting today. So, Keelan, maybe we can start sharing the presentation.
I won't blow the presentation up fully, just in concern that it just goes black from my end. So hopefully everyone can see it now.
Yep.
Okay. Yeah, so first of all, thank you for giving us the opportunity to present the findings and recommendations of our report. And the title of our report is From Diagnosis to End of Life, the lived experiences of dementia care and support. The report I will be talking about today considers current provision of dementia care, but it was mostly research and written before the COVID-19 crisis. And our report analyzes the gaps between what care and support the current guidance and the legislation affords to people living with dementia, and what care and support people are receiving from diagnosis to end of life. And of course, it contained, as you might have seen, specific recommendations to local decision makers to help them address the needs of people living with dementia. Just to bear in mind that these reports contains findings that are based on research produced in different areas of England. So some of the findings might resonate with you, but some other might not resonate with you at all. Keelan, next slide, please. So in terms of how we structured the report, we used the 4 stages of the NHS England Wealth Pathway. And our objective was to show the discrepancy between what people living with dementia are entitled to in terms of care and support, and what people are actually receiving based on their own experiences. So we gather our evidence in this way. So we use national guidance and legislation as a benchmark against what people have told us about their own experiences of care and support. We conducted literature review of existing pathways, standards, and data sets. And we also arranged a series of focus groups and interviews with people affected by dementia. And of course, we interviewed and surveyed a series of health and social care professionals, so GPs, nurses, dementia support workers, and so on and so forth. Next slide, please. I think one of the recurring themes across all stages of the pathway that we found was a sense of disjointed and fragmented care. And I've collected here some of the quotes from the reports that show the impact of these disjointed care. However, I just want to say that throughout the research, we did find a series of good practice happening in parts of the country, and there has been significant progress on improving dementia care and support over the years, but we still think there is work to be done, and this is why we have compiled a range of recommendations that can help you to improve dementia care. Next slide, please, Keelan. I will start from the first stage of the pathway, diagnosing well, and I will give an overview of the key findings that we found in relation to this stage of the pathway. So one of the things that we found is that people sometimes are being misdiagnosed, especially younger people, or opportunities to identify dementia early are being missed. And one of the reasons that we find behind this is that sometimes GPs don't feel they have sufficient basic and post-qualifying training in dementia. So in a way, their overall knowledge of the condition is quite low. We also found that sometimes referral processes can be quite confusing for people with dementia, and they feel kind of daunted about what comes next. And we also found that there is a variation between memory services across England and limited performance data. And this can make the initiations of service improvement projects quite challenging. And lastly, another thing that we found is that sometimes the diagnosis, when it's delivered, is not delivered correctly. So sometimes it often focuses on what people can no longer do rather than what they can do. And sometimes the information, tailored information, is not provided to the patient, and the subtype is not even provided either. So we do have a series of recommendations that can help address the points I've raised just now. And one of these is that we recommend the CCGs have a dedicated dementia lead that should be responsible for ensuring the delivery of training to GPs on referral criteria, diagnosis, and personalized care and support planning. And this will help GPs to make appropriate referrals and help them avoid misdiagnosis. Also, we recommend new ways of working within primary care. We've seen that sometimes GPs don't have enough time to assess potential dementia and engage in meaningful conversation with the patient at primary care level. So we think that it could be good to conduct longer appointments at primary care level, or alternatively, other members of the primary care team can become involved in a diagnostic process. So for example, a nurse could undertake a brief cognitive assessment screen in addition to taking a blood sample. Also, we recommended to facilitate dementia diagnosis, especially complex cases of dementia. There should be formalized arrangements that allow multidisciplinary team meetings between memory service clinician, neurology, and neuroradiology. And also, we heard that access to the right professionals sometimes at the right time during the diagnostic process can be difficult for people with dementia. So we do believe the memory services should have clear referral pathways to make sure that people with dementia have access to allied professionals, so psychiatrists, psychologists, occupational therapists, and so on and so forth. And also, we think the memory services should run an open referral system, which means accepting referrals from sources other than primary care, including hospitals, social services, patients, and caring themselves, because this would offer expertise, especially in urgent or crisis situations. And also, we do think the memory services should include dementia advisor services, and people should be automatically referred to the service unless they opt out. So we basically have seen that where dementia advisor services are co-located within diagnostic services, this highly increases the number of survey users which are recruited at the point of diagnosis. And also, one of the issues that we found is that since the diagnostic services are commissioned to provide a diagnostic service only, this sometimes leads to a systematic pressure to discharge patients once the diagnosis has been delivered. And this, of course, can prevent services from offering follow-up opportunities for patients who may have questions about their diagnosis and its implications. So we do recommend that people with dementia have access to follow-up opportunities to discuss a diagnosis. Can we change slide, please, Keelan? So moving on to the supporting well stage of the pathway, and by supporting well, we mean caring support, which is provided to people with dementia within 1 year of diagnosis. We found other very significant findings. So one of the finding is that sometimes information which is provided at the point of diagnosis is not being delivered in the right way. So sometimes people with dementia receive too much information, so they feel kind of overwhelmed by the amount of information they receive, because professionals try to address everything at the point of diagnosis, and that is counterproductive. Or alternatively, they receive too little information, and this is also problematic. Another finding is that people are struggling to access a care coordinator. We know under NICE guidance, everyone diagnosed with dementia should have access to a named health or social care professionals who should coordinate their care from the point of diagnosis to the end of life. But we've seen that across England, there is a lack of clarity around the role of the care coordinator, specifically who does it and what it involves. So people with dementia and carers do not know who their care coordinator is. Professionals do not know whether they are the named care coordinator. So in a way, we think that a care coordinator will significantly help people with dementia navigate the complexity of the health and social care system to make sure that they get the right care and support in place. Also, about care planning and advanced care planning, we've seen that sometimes can be insufficient and the needs of people with dementia are not considered. And we've seen that sometimes care plans, some people with dementia don't have care plans, or sometimes they do have care plans, but they are unaware that they have one. And so this is not what should happen, because professionals should provide a copy of the plan to the person and family members, and care plans should be drafted in consultation with people with dementia. And also we've seen that unfortunately people with dementia are explaining their story multiple times to different healthcare professionals, and this leads to a kind of frustration both from the person affected by dementia and the professional itself. And also another finding is that unfortunately the provision of post-diagnostic support intervention can be quite variable and inappropriate. So we've seen specifically that people aren't being offered them as standard, or they are struggling to access them. And specifically, there are barriers for people from many groups, including from BME communities and LGBT communities, but even people with young onset dementia who are struggling to access post-diagnostic support intervention that are appropriate to them. We have developed, next slide, please, Keelan. We have developed a series of recommendations to address these problems. And one recommendation is that all people with dementia should have a named care coordinator. Again, that this person should ensure they know how to contact them for consistent and practical follow-up care and support. We believe that evidence-based post-diagnostic support intervention should be provided for people with dementia and their carers. And these should be appropriate and tailored considering age, ethnicity, religion, gender, and sexual orientation. So we usually suggest raising awareness of dementia in different languages, making links with communities and faith groups, ensuring interpreters are booked for appointments. And also what we recommend is that it's important to locate dementia advisors, not only within memory services, but also within primary care, because we've seen that by doing that, GPs can actually focus on the health-related issues of the patient. And also we think there should be clarity on where responsibility sits for the initiations of medicines and follow-up appointments for people with all types of dementia. And also there should be more prominent role for advanced care planning within post-diagnostic support. We've seen there were mixed views from people on when advanced care planning conversations should happen. This is quite a sensitive topic. And some professionals told us that they lacked training and felt uncomfortable initiating these conversations. So moving on to the living well stage of the pathway. And by living well, we mean what happens a year after diagnosis. We found that people sometimes receive limited access to proactive and ongoing care and support. And the follow-up care is not the same for everyone. And the main issues that we find were mainly around the consistency of follow-up, mainly within primary care, and the quality of care plan reviews. And one of the biggest findings in this stage of the pathway was that, unfortunately, carers are struggling to access support services for their own well-being. And we know that many people with dementia receive most of their support from their primary informal carer. And the main problems that we found are around carers assessments, which are not being offered to carers, but also respite care themselves. And also, what we found is that sometimes hospitals and care homes do not take into account the specific needs of people with dementia. So you know that hospital admissions are better to be avoided for people with dementia. They are an unsuitable environment for people with dementia. However, we've seen that across England, emergency hospital admissions have increased, and that, according to us, is due to a poor integrated working between health and care services, or simply lack of appropriate care provided in the community. However, sometimes people with dementia need to be admitted to hospitals, and we want them to receive appropriate care, and sometimes this doesn't happen. So, moving on to the recommendations related to this stage of the pathway. What we really recommend is there should be support for carers, especially around respite care. So we recommend that to provide straightforward methods of booking overnight care in advance, and also making sure that carers have access to a list of recommended local respite care services they can have access to. And also, yes, we do recommend that people have increased follow-up and step-up care post-diagnosis, and they have access to ongoing opportunities to access support interventions. And also what we think is important as well is that sometimes there is a lack of clinical input within care homes. And so we think that local multidisciplinary teams should be formed to assist local care homes. And these teams should include allied health professionals, because they will be able to upskill care home staff, and that will reduce hospital admissions. And lastly, our recommendation is that all professionals who work directly with people affected by dementia should be trained to the Tier 2 of the NHS PEC Dementia Training Standard Framework, which is basically a framework that was commissioned by the Department of Health in collaborations by Skills for Health and Health Education England. The last section of this presentation is about dying well, and so end-of-life care. And shortly, I will go through the findings. And one of the main findings related to end-of-life care of people living with dementia is that people often struggle to access palliative care, including end-of-life care. And that can be due to many different reasons, including lack of staff skills, the difficulty that people with dementia have in communicating their symptoms, and the ability of professionals to understand the symptoms that they're actually displaying, but also the lack of awareness that dementia is a terminal condition. And also another finding is that advanced decisions are sometimes ignored, and that means that the interests of people and their wishes at the end of life are not being fulfilled. So we think that in order to address the points I've raised, it's important to manage hospitalization as part of end-of-life care, and that can be mitigated by integrating services, upskilling care home staff, and increasing access to out-of-hours specialist support. As I was saying before, making sure that local care homes are assisted by local multidisciplinary teams, including palliative care teams. And then lastly, the local services should be set up to ensure the professionals who are involved in end-of-life care can easily and quickly access advanced care plans. So to conclude really, and this is the last slide of the presentation, we know that from diagnosis to end of life, people with dementia face significant challenges in accessing the care and support that they need. And as I showed you in this presentation, a recurring theme is a sense of disjointed, fragmented care across England. And while we think the government and national bodies need to make further progress on dementia care quality and outcomes, we believe that local decision makers and professionals are those who are best placed to take ownership of developing dementia pathways. So thank you very much for listening to our presentation. Keelan and I will be happy to answer any questions you might have now. And so we will be really interested in hearing your thoughts on any of the recommendations that I just presented.
Thank you, Dora, for a fascinating presentation. I've got 3 hands up so far. The first was Councillor Doherty, then Councillor Vickers, and then Gary Poulsen.
Thank you, Laura, for that presentation. It was really interesting. And I was pleased that you went through the local recommendations, because I noted in the report there's a lot of national recommendations there as well. Just picking up on what you said at the start of the presentation, you said there was a really mixed picture throughout the UK. And I guess because you've picked up on the local recommendations, it's an understanding of what that mixed picture looks like here in West Berkshire. I don't know if you can answer that directly, or if it's something that we'll actually have to take up if we want to take this forward to understand which of those points need addressing here in West Berkshire. I'm aware that we have done quite a bit of dementia work over the previous years. I know we've done sort of dementia awareness and different aspects of that throughout the last administration. So I'm just sort of conscious of there's a list of local recommendations, and it may be that we need to do all of them, it may mean we need to do some of them, and I just wonder if you know anything about West Berkshire specifically, or if there's anybody, and I'm looking at Shiraz has got her hand up, that can come in, because it's great, and I understand you've taken a sort of complete picture, but we need to understand what that looks like here in West Berkshire and what we need to be doing as local leaders.
Councillor Vickers.
Thank you. Sorry, I was.
Sorry, Chairman. I thought Laura was about to answer.
I was just taking them in order, but if you rather I did that, I don't mind.
All right. Is there going to be an answer, or does the answers come at the end of all the questions?
As you wish, really. I can also answer it right now.
Thank you.
It's going to be a very short answer. We don't have specific recommendations for West Berkshire, really. Our recommendations are quite general, but I'm really happy to work with you to understand what is actually working already in West Berkshire and what could be improved. To give an example of the work I've been conducting recently, I've been attending a series of dementia strategy steering work group meetings in other local authorities, including Buckinghamshire. And what I've been doing is to help them really with drafting the recommendations, specifically direction plans, so the outcome measures and the actions. So I think I would be really happy to work with you on this.
Okay, thank you. Thank you, Laura.
Councillor Vickers.
Thank you. I wanted to say thank you for that very valuable report. I think it's a sort of education in itself, listening to it. This is a subject that's growing, a condition that's growing, and I think we all need training, we all need awareness training. I think we're all aware of that. But I think you're specific. I assume this is something that will be under the local authority to do, would to be make sure all the carers in the care homes are properly trained and understand this. And I think this is possibly to some extent relative to what's going on at the moment with the pandemic, but understanding dementia is just so crucial. And also I think you point out in your report that one of the things you'd like us to do is to recognise in the Joint Health and Wellbeing Strategy that this should be a priority. And in another report we have today, dementia is not included in one of the priorities that are put before us for the Joint Health and Wellbeing Strategy. And that has already been highlighted by the response the council has got so far. So it really, there is a blanket supporting vulnerable people, but dementia is such a crucial thing that it needs to be recognised of its own, because it's not getting the recognition and the care it needs. And one specific point that has been raised with me, and I think it's an ongoing thing, that, if you have a health condition, it's this integration of health and social care. A health condition, your care is free at the point of return. If it comes under social care, you have to pay. And this is what we're doing, the confusion about what dementia is. A lot of what happens during the life cycle of people with dementia, but what happens to them comes under social care, because there are medical things, but it's a deterioration of what you can do, and it seems to come under social care, so that all the carers and all the services they have to pay for or be assessed. If they have very little resources, then they will be supported. If they're just about managing that jam section, they will have to pay and they will struggle. I think it's just by coincidence we've had the questions at the beginning of our meeting, the public questions, which I don't know whether you heard, which were all about dementia. And I think that is just a coincidence, actually. So that just highlights the predicament of a carer. And I know that one of the concerns of carers and people is that to come to the end of life in particular, their condition is very much a medical condition. So could that be recognised? And so could be at least towards the end, when it's becoming very medicalised and the individual is really needing medical care, could that be recognised? Could that be, considered medically and be paid for? And should they not be struggling to access funds there?
No, I'm not sure you want to answer that or not. I think it was more of a statement really than anything else, but.
Yeah, quickly I can say that, dementia is, the numbers of people with dementia are high and they will increase. If you see trends, you will see that people with dementia will be even more. And as you were rightly saying, Councillor Vickers, people with dementia suffer from comorbidity as well. So they do suffer from other health conditions. So of course, the impact on their mental health and the physical health is even worse. And everything you said, I completely agree with that. And I guess our national policy and public affairs team is also working out our policy positions in relation to the plans for long-term social care reform, and that will include also the idea of making sure that people with dementia and in general, like people who rely on social care won't need to pay for their care anymore. But it's important, and I think this is the very key theme of these reports, is making sure that not only people don't have to pay for their care, but that the quality of the care and the support they receive is also high quality.
Thank you. Gary.
Thank you, Chairman. Thank you very much, Laura. I'm really, it's a bit parochial, this really, but it is affected by national policy of Alzheimer's. You may probably not aware, Laura, that you have a policy of not permitting your local branches to be involved with arranging transport for people to get to local support groups, and it's very important. Up until about 3 years ago, we were providing regular minibus transport for Alzheimer's sufferers, dementia sufferers, you know, and quite often their partners or carers to those valuable support meetings. That's the living well element, really. And so I'm just really feeding that back to you, because I think it's very important that National Alzheimer's reconsider allowing their local coordinators to be involved in the coordination of transport for people to get to these really important little support groups, which do improve the quality of life for people and give some respite as well for their carers. Thanks, Chairman.
Gillian or Joanne, would you like to answer this question?
Yeah, thank you. Thank you, Gary. I just wanted to say that I'm the manager for the Dementia Care Advisor Service here in West Berkshire and in Reading, and we provide a contracted service here in West Berkshire for dementia support, and unfortunately transport isn't in that contract. So I completely understand that. I was around when Alzheimer's Society had branches, and I understand you know, where you're coming from with transport and transport issues. Unfortunately, in this particular instance, we're constrained by what the contract requires us to do. Nationally, we do provide a lot of voluntary income into existing services, but as you can imagine, we're under huge financial constraints, and we've all had significant cuts in services. But we do strive to provide groups and services ourselves, and we are always continuing to look at ways to improve access to those services. But so I do appreciate your
There's a big barrier.
Without groups and services, our dementia support sometimes isn't as valuable. So we do appreciate that.
Can I come on to Shires?
Thank you, Chair. Thank you, Laura, for a very comprehensive and a really in-depth view of looking through the whole pathway of dementia and the focus that it can bring us on this subject. As Councillor Doherty mentioned, that there was a lot of work done, and if Bal, our GP representation, was here, he'd outline a lot of that. So we did some very specific work in Newbury around dementia diagnosis, making dementia friendly practices. There was also a piece of work brought to our health and wellbeing steering group around having buildings built to be dementia friendly. So we start in the planning stage when housing is being built and care homes are being built, to consider. So, and I think it's really right you've brought this round again, because we had quite a, sort of focused time when we were working on this. And I think it's the right time to look at some of your recommendations and look at where there are some gaps, because, there's a lot there. There's a lot we are doing, but there's a lot we could be doing better. So just some thoughts for me, really, in the sense around the work that we're doing at the moment, where we have anticipatory care plans, but they are for complex patients, and dementia patients will be amongst those. But I think having a focus on dementia may help us pick that up. We also have something called connected care, where plans are shared across our local partners, and that helps us having some information that is across the sector. It could be better, and I think, again, I think your presentation helps us think about what's the focus we can have around dementia patients. The other bit that we're doing in our local integration board, and I welcome you to come and present there, Laura, because we're working on MDTs using something called the IPA tool, which is risk stratified data, looking at patients that have specific diagnosis. And there might be something we can do specific with dementia, because these MDTs are working with health and social care, and we're looking at sort of community nursing, GPs, and our social care partners. and widening those and including maybe the other partners that you've recommended in some of your recommendations would really help us think in that space. The other element we have, for end of life, I'd really like to understand a bit more about that. So I'd welcome you to join our end of life steering group, because we're doing some work. This is across Berkshire West, so this is Reading, Wokingham and West Berkshire, where we're working with all our partners to draw them together to work much better. And again, having a focus on dementia may bring another dimension for us. And I think just going to Councillor Vickers' point about the balance of health and social care, dementia had, and my mother had dementia, so I understand I've got a very individual view of this as well. Some of the specific needs that dementia patients have are social care needs, and there are health needs as well. And I do find we are quite balanced about that, but I think a view on getting that balance better, because the reason I want to explore the end of life element is I think training really spoke to me. I think there's an element of training around people understanding when dementia patients do have end of life needs. And I think, again, I'd welcome a conversation with you around that. So I think if you could, your slides, I'm presuming, will be shared with us, because there's a number of forums I'd want to share them with around our mental health forum, our local integration board, as well as our end of life work, to sort of give this focus. And if we can have your contact details as well, that would be really helpful, and we can get in touch about how we move forward some of these elements. So thank you. That was a really in-depth search, and it's heartening to know there are things in there we are doing, but there are things we can do better as well. So thank you very much for that.
Thank you. I have Councillor Bridgman.
Thank you, Chairman, and thank you for the presentation. I think Councillor Doherty puts her finger on one of the bits of the pulse here, where we need to clarify what we're already doing in order to understand which of the recommendations we might wish to consider. And with my adult social care hat on, I'd also, I'm afraid, going to say, and the cost of implementing those recommendations, because we've got to accept that the money comes into it somewhere. I think that this is the right place to have the discussion. Within the adult social care fraternity, we have already had, and sorority, I should say, I shouldn't just say fraternity, should I? We have had discussions with particular advocates for the Alzheimer's Society and for dementia patients. And the previous questioner is one of those, in order to clarify what we're actually doing on the ground and what might be done. And I think it is obvious that COVID has got in the way, particularly in the area of care home visiting. That is something I fully understand. Direct touch, direct facial recognition for dementia sufferers living in a care home is unbelievably important, and yet we also have a wider responsibility to the staff and patients and residents in order to ensure that we have safe visiting. And at the moment we have really, apart from end of life, we have no visiting because of lockdown. But this is the right place, because we're trying to draw together, I think, the CCG, primary care, acute care, adult social care, as a provider of care home services, and as a link into the market. You will know that we do have dementia provision in our own West Berkshire care homes, and that I think that is something quite important to recognise, because a lot of work has gone on in the care homes to make those bits of the care homes which are dementia, parts of the care home dementia friendly. I've seen work gone in for example, Birchwood, where a lot of work has gone into colour, signage, everything to do with making that a friendly environment for dementia residents. We've also done work in our own, for example, in the Kennet Centre car park to make it dementia friendly. So we are doing work. I don't know that we've done all the work we can, and I'd like to see how we can take this conversation forward and engage officers and dementia and, as I say, the other bits of the health system. And I think the Shara's referring to you attending and making a presentation to the Locality Integration Board is a very good idea, because that's where the sort of health partners come together to have a conversation. So I would look forward to that happening, and us progressing a lot of this stuff once we're out of lockdown, because that is imposing quite a restriction on what we can do in the care homes at the moment. Thank you, and thank you, Chairman.
Joanne Rice.
Hi, yes, I just wanted to pick up on what Councillor Bridgman just said there. Thank you. I can help you understand what can be implemented locally, especially in terms of what works, because I work across several different areas. I also cover Oxfordshire and Milton Keynes, and I've worked in areas such as Devon, which has had some really great successes in some of those areas. I can also provide you with information about what works and is free, because it works, because it just could just be a change of implementation. And I can also help you provide people with dementia as a focus group, as a vital sort of review group, as somebody who can actually give you that voice, because we have service users in West Berkshire. We have a very strong referral pathway from the memory clinic, and we do have a good, strong dementia care advisor service, and that does work really well compared to other areas. So, but there's things like the open referral sources to memory clinics, a dedicated dementia lead, those sorts of things I think would really strengthen the system. And I think if you want to invite me to give you the clarity of what works in other areas, I'm happy to join in that work. Plus, also I can feed back into our service and directly to our service users, who are the most valuable resource that we have as far as feedback goes here in this area. So I'm happy to help you out with that.
Thank you, Joanne. And finally, we've got Andrew Sharp.
Hi, Joanne, I'd like to link up with you afterwards to obviously discuss focus groups, things like that. So if you could share your email, that'd be brilliant. I just want to touch on some issues which are sort of COVID related, things like the memory clinic being relatively suspended, is my understanding, which one of the issues that I put in the chat, but it's really, really important, is that for family carers with those with dementia in lockdown, you know, they've been put in a really difficult position, and there didn't seem to be, you know, a huge provision of help for them. So I just think in terms of the COVID learning and also that position with carers, because we've touched on it, Councillor Vickers touched on it, some of the questions touched on it. You know, I think it's really interesting that, you know, the level of continuing healthcare in West Berks, and in fact Berkshire West, is some of the lowest in the country. So if you do find yourself in this, and those comments from the report about, you know, we didn't seem to get the help, or every time we did something it was a real challenge. We have done some fantastic work in West Berkshire. The dementia enabled design, as Councillor Bridgman touched on, is absolutely fabulous. The work that Public Health have done on dementia awareness, the Dementia Friends programme, you know, all that stuff is just, you know, to be applauded. But I just wonder whether, you know, we need to look at, as we talked about, some of these gaps. And I think the integration board might be a place to take some of this, because this is definitely where health and social care comes together. And if one isn't working in harmony with the other, it can let some people fall through the cracks. But yeah, excellent presentation. Thank you.
Thank you. Laura, could I echo that and say a fantastic presentation? Thank you very much indeed to you and Keelan. And we hope we can work more and more with you. I've had a couple of requests in for a 5-minute comfort break. So can we just literally make it 5 minutes, please? Because we do have a tough agenda to follow. Come on. Right, I think we'll try and get going again if we could, please. I know one or two people have had to drop out at, but the next item on the agenda is the joint health and wellbeing strategy. Could I ask Sarah Rayfield, please, to provide an update?
Yes, thank you, Chair, and thanks for the opportunity to update the board. I have a short presentation to share our update so far. I'll just bring that up. So as we've presented this roadmap, I think, before, but this just shows the journey of the strategy from start to finish. And we're currently at the point of public engagements involving the public. Prior to this point, we started with evaluating the current strategies, identifying the needs of the population through data analysis and stakeholder engagement. We had a long list of priorities to consider for inclusion, and through a series of online workshops over the summer, we refined those down to our list of 11 potential priorities. And those are what we're currently engaging with the public on, providing a framework for those conversations to develop the final strategy. Throughout the earlier engagement work with stakeholders and other professionals, we did identify a number of themes to be included in the final strategy, and those include that of empowerment and self-care, digital enablement, integration, prevention and recovery from COVID-19. These are our potential priorities, so the 11 that we are taking out to the public, as we've discussed at a previous board, I think. So you can see them there. So they are quite broad and overlapping in some areas, but we made a decision to keep them as this in order to have the conversations. And just of note, we have a page on the Berkshire West CCG website, which details the strategy, includes the roadmap, further information about our journey so far, including the data analysis, and it also includes a British Sign Language version, translation of the strategy development. It includes an easy read version of the priorities and what they mean, along with a more detailed version of the priorities and what they mean as well. It includes links to the survey, which is ongoing at the moment, and we also have a Twitter and a Facebook page, which we are using to promote public engagement, and we have a dedicated email address for which we're asking people to respond to if they wish, and if they feel they can't complete the survey but still want their voices to be heard, then that's another mechanism that people can get involved. So at the moment we are doing our public engagement, and this is forming a number of different strands. Primarily the online survey, which is hosted through West Berkshire Council's consultation portal. This is being promoted using the 3 local authority comms teams and the CCG comms. We're using some of the COVID communications at the moment and the residents' newsletters to promote the survey. We've been holding a number of different focus groups supported by the 3 Health Watch organisations across the area. These have been focused on different target groups, including carers, young people, those from ethnic diverse communities, maternity and older people, and carers and learning disability community as well. We've had an ask out to the voluntary sector organisations with a request for them to engage with the survey and feed back into the consultation, and there's a toolkit which can be provided on request through the Gmail account. We've run a series of 3 public meetings across the last 3 weeks, which have been open to residents from all local authorities, and they've been reasonably well attended with some rich discussion, and we're just collating the responses from that. And there's been a number of different steering groups and other organisations that we've either engaged with by attending their meetings, or we've been able to send them the toolkit and ask them to engage with their members and feedback to us. So I've just got some early findings from the survey to share with you. I think it's important to note that this is partway through the process and these may change. But as of yesterday, so hot off the press, we had just under 1,600 responses to the survey. The numbers are getting more evenly spread, but still most of the responses are from West Berkshire at 620, 542 from Reading and 435 from Wokingham. In terms of those who've responded so far from West Berkshire, the vast majority are female. We have got a bit of a spread of ages, although the highest numbers are from the 55 to 64 age group, with the lowest on the 18 to 24. We have had a bit of a push to local schools and the peer mentoring network, so we have had some responses from people who are under 18. In terms of the ethnicity, obviously the vast majority of people responding have self-declared as white or white British. I think it's important to note that this particular question, we have quite a big drop off. So although we've got 1,600 responses overall, only 700 people responded to this question. So 281 from West Berkshire. So out of those that responded, we are noticing a gap in really getting the views from more diverse ethnic communities. And in terms of individuals who self-declared as an other ethnic group, you can see along the bottom there's quite a wide range of different groups. In terms of organisations that have responded in West Berkshire via the survey, as you can see, there's quite a long list of people, and we've been well supported by the voluntary sector organisations to push out this survey and to encourage people to respond. So thank you to them. One of the questions that we ask is asking people to rank the potential priorities, and then we get a collated response in the end, sort of scoring each of them. And this is how it's coming out so far. As I said, it may be subject to change. So the top priority that people would choose is supporting vulnerable people to live healthy lives, followed by helping families and children in the early years, and then good mental health and wellbeing for all children and young people. And then the fourth one is reducing the differences in health between different groups of people, so health inequalities. As you can see, the rest of the list as well. Another question we ask in order to really deep dive into what people think about the priorities and what they think, where they feel action needs to be taken, is about how much change people feel is required. So it's more nuanced than this, and we do sort of ask some change, not so much change, but just looking at the two extremes of significant change and no change required. Again, we're coming out with mental health of children and young people near the top of the most change required, followed by mental health in adults, and then supporting vulnerable people again to live healthy lives. So as I've said, we've done a number of bits of public engagement so far, and the focus groups supported by Healthwatch, the meetings, we've got future focus groups planned, and different things, including Berkshire West Your Way held some focus groups for us, Talkback has held a number of focus groups. We're having feedback coming in all the time from organisations, with talking to their members, and we're having a bigger push on increasing engagement on social media, and particularly targeting sponsored ads to address the demographics and the groups that we're having less engagement with so far. What we wanted to bring to the board today, though, is really a request to extend our period of public engagement. One thing we have found since coming back after Christmas is that with the new national restrictions, that has hampered our ability to engage as extensively as we would like to, partly due to the pressures on the general public at the moment, particularly thinking about specific groups such as families with young children, with schools being closed, and particularly with carers and the pressures that they're facing at the moment. We originally were going to have our public engagement up until the end of January. Our request, so we would recommend that this period of public engagement is extended until the end of February to allow us to further target the gaps that we've identified in our engagement so far and ensure that we can have robust consultation with the public. This would lead to a delay in the production of the strategy, which at present was planned to have the first final draft by early March, and this would delay this to early April. So in terms of that, these are our next steps. So we would recommend that we extend this public engagement till the end of February. This would lead to our first draft of the strategy in early April, and then the plans are to have a subsequent consultation on the final draft strategy following that. And I will attempt to stop sharing, and I'm happy to take questions.
I have hands up from Councillor Bridgman, Councillor Vickers, Meriden Peachy, and then Sean Murphy. Councillor Bridgman.
Thank you. My question is, given the position generally and the announcement yesterday about the continuation of national lockdown, is the end of February sufficient for you to get to do what you want to do? I would have thought you need to push this out much further.
I think 6 months.
Yeah, and I think it is something that we'd considered and trying to understand when's the best time. I mean, I suppose we have done a lot. You know, we're well supported by you know, the groups and the other people. You know, our engagement is planned by it's been very co-produced by a big task and finish group and very supported. I suppose it's trying to find that balance between wanting to ensure that we have enough engagement, but not sort of dragging it on forever, as I suppose, and that's where we've come to the conclusions at the end of February.
Councillor Vickers.
Thank you for that presentation. Yes, I mean, I'd support what Councillor Bridgman has just said, that, you know, prolong it. I mean, this is for 10 years. This is really important consultation. I mean, I think we all struggle with how we get people to respond. It's really difficult, even outside of a pandemic, actually getting people to motivated to respond. And the number you've got back so far is really is poor considering our population. And looking at the breadth of the responses, it's the usual suspects, isn't it? You know, the older people always get in there. The ones that we really want to focus in, you know, 18 to 24s, not there. You know, schools, yes, you can get at them. It's really so difficult. How do we motivate them to respond? Have we got, I mean, I'm thinking, what were the results of the last consultation? What did we achieve following in the last 10 years? Did we actually achieve the things that were the priorities? Where's the feedback about that? That would motivate people to respond. They really got to feel that it's worthwhile responding. It's not just an exercise. It's not just a ticking the box thing. There's a mention of, oh, what about COVID? Things might change. Well, of course they're going to change, but the consultation must be revisited. You don't just do a consultation and then all goes quiet. You have to come back every few years and say, these are the priorities. This is what we've done. This is maybe something we need to focus on because of our responses and because of what's happened. So it's got to be live. It's really got to be something that you're working on, and you can show the public that you're working on it. And that is how you'll get people to respond, when they feel it's really worthwhile and they're getting proper feedback. But yeah, I mean, let's get out there and do our very best, and let's look at some innovative ways of getting people to come along and give us their views. I don't know a lot about things like citizens' assemblies, and they're probably difficult to organise, but, you know, get people to sort of feel that this is their health. You'd have thought if people don't realise that their health and well-being is important now, they never ever will. So they care, they're out there and they care, but they're not letting you know what they think.
Thank you. Can we move on to Meriden Peachy, please?
Thank you. I think people have recognised that this process has been going on for quite some time since you all agreed to develop this strategy, and life has changed significantly. But the content has also changed. I think Sarah has highlighted that one of the underpinning themes will be about COVID recovery, because actually quite a lot of morbidity is going to be different than it was before. And I think the second important point, I think it was mentioned actually, that the Integrated Care Partnership would really like this strategy to be key to their delivery across partners. So it will be an opportunity to really help shape the NHS in terms of health improvement. So I think, just to echo your point, it is quite an important strategy when we get to that point.
Thank you. Sean?
Thank you, Chairman. The question I was going to ask Sarah was about, obviously we're in a kind of very developing situation, and when we get to item 13, we've obviously got the Marmot review and some of the issues out of that. The one thing that occurred to me was that one of the fast developing issues is the issue of food, nutrition, obesity, food inequalities and things like that. Will there be an opportunity with the strategy to revisit some of those issues, given the speed at which that agenda in particular is developing?
think there'll be an opportunity as we kind of use the public engagement to refine down our areas of what we wish to include in the final strategy, and the sort of discussion all the way through. It's been quite clear that people want to concentrate on a couple of defined areas, sort of 3 specific things, so that we can do a smaller number of things well. I think there's plenty of opportunity within those and ongoing to kind of incorporate things that are happening at, things that are changing, and to really refine what we mean by those. This is kind of our framework for consultation at this point, but I don't think anything is sort of set in stone, as it were. And I completely appreciate your point, Sean, that things are changing all the time, and we're learning more about COVID recovery and the impacts and what changes that's going to have for the future.
This meeting is scheduled to finish by 12, so can I encourage brevity? Matt?
Yeah, thanks. So it's just firstly, thanks Sarah and her team, because I think it has been really difficult to engage. I guess I just want to challenge, actually, many of the challenges, they might have been amplified throughout the pandemic, but they remain. We know what are driving inequalities. We know it's the places we live, how we work, our jobs. So we know what the challenges are. So I would just question how far we do keep pushing back this strategy in terms of actually when we know what those parties should be and how we do influence and shape people's health and well-being. So I just wanted to make that point, but thanks to Sarah and the team for continuing the hard work on this.
Finally, Andrew Sharp.
Yeah, I'd like to reiterate Matt's thanks to the team, because they have battled through all sorts of things, including the pandemic, stopping and starting things. I agree really with Councillor Bridgman and Vickers that this is such a key thing, that if we can at all offer an extension, perhaps compromise the end of March or something, I don't know, but we do have to get it done. But the other thing that we've sort of noticed is the reticence for system leaders to really get behind this and back it in the way that I think it needs, because we're asking why the public aren't perhaps getting involved and joining in. Well, where are the system leaders saying, via videos and everything else, this is really, really important? If they don't show that it's important in the same way, it's such a difference between the hospital building program, which have had thousands of responses, thousands of views, and people can see why that's important. And I don't think we've managed to generate the same sort of, this is equally important. So I'd like to see the system leaders across the patch, health, social care, public health, getting onto this, putting videos out saying, please come and do this.
Councillor Jones.
So very quickly, Chairman, thank you. I've listened to all the debates about whether we should do a shorter timescale or a longer one. I understand the pleas for getting it right, because it is so important. But if we are going to respond to the public, as Councillor Vickers is talking about, we need to finish the job so that we can actually start to publish and implement the strategy, because that's the best feedback we can give. We need to give people the confidence that we're actually going to do something. And whilst we are simply consulting and debating strategy, we're not actually feeding back or doing anything. So I'd agree with the February timescale, I think.
Thank you. Sarah, I've been swapping chats with Matt Pearce, and if you're happy, he's suggesting that item 13, tackling health inequalities, will be able to report far better in the next meeting than this one. So if we don't mind, we'll slip that item. But Matt, can we move on to the local outbreak control plan?
Sorry, Councillor Wilson, can I just check what the decision was on that for Sarah in terms of?
We're going to slip it to the next meeting.
Sorry, in terms of the health and wellbeing strategy, are we agreeing to?
There's a decision needed as to whether we extend it or not.
Yes.
My inclination would be to slip it a little, but not too much.
Okay, I think it's in the paper to the end of February. Is that right, Sarah?
Yeah.
Surely we should vote. Surely we all vote.
Well, I think we should. We should have 2 options. The first one to the end of February, the second one to the end of March. Does that make sense?
Okay.
Okay, I show of hands, first to the end of February. 1, 2, 3, 4, 5, is that? Yeah. And then to the end of March? It's looking like February to me.
Thank you.
Okay. Thank you, Matt.
Thank you. Sorry about that.
Right.
Very quick from me. I think many of our audience and those on the board recognise that we have a local outbreak engagement board, but the next one being next Monday, and many of that data is explained in detail there. So really, we're in a more favourable position with our rates. So they continue on a downward trend, although not quite as quickly as we would have hoped and have seen during the first wave. So our current 7-day average is around 265 per 100,000, which is about 15% lower than the week before and 20% lower than the week before that. And we're continuing to see a rate also within those over 60 or more. Very positive, but again, still a long way to go. Sadly, we are still seeing the number of deaths increase. So there's been 183 deaths in West Berkshire during the pandemic, and 6 deaths were recorded in the latest weeks of data that we have between the 9th and 15th of January. In terms of the actions to control, obviously we're still following our outbreak control plan. We're working really fast to develop a local offer for community testing, which we're hoping will go live towards the beginning and middle of February. So that would be very much for the key workers, so those that are really unable to work at home and providing those vital services across society. And many of you be aware in terms of the vaccinations that are taking place both at the racecourse and also at Pangbourne Surgery, and I'm also getting support in terms of vaccinations at hospital hubs in Wokingham and the Royal Berkshire Hospital for health and social care staff. All care homes now should have been vaccinated, though there will be a few that haven't been because they may have tested positive within the last month or so, or possibly refused. And the aim is to get over 80s vaccinated by the end of the month. But just to reinforce a point really that the vaccination programme is being led by the NHS. So that's, sorry, I'm going off. That's probably all from me. I think the other thing we're just mentioning is, despite the numbers going down, we are seeing still a lot of outbreaks in the community. So in our high-risk settings, whether that be care homes, in early years settings, in workplaces, and I know Sean's team are working hard to manage those. So that's all from me, Chair. Thanks.
Councillor Vickers.
Thank you. I think you mentioned at the last LOEB, Matt, that I asked about refusals, and you said they were low, minimal. Is that still the case? And is there any work that's being done, any more education about the importance of this vaccine in the population, or is that not considered necessary?
Sorry, I just missed the first bit of your question, Councillor Vickers. What was low? Sorry.
Sorry, about refusals.
Oh, refusals.
What are the number of refusals? Is it still considered to be minimal? Is there any work that needs doing as regards educating the public? Are there any groups of people in our population that are particularly skeptical about this vaccine that we need to support in order to make sure they're properly informed?
Yeah, if I'm honest, I don't think we have that level of data at the moment. So I think that's coming through all the time. We are starting to get ethnicity data, and we know in other vaccination programs there are certain ethnic minority groups that we know have low uptake generally in vaccinations, and the assumption is that will likely apply with regards to COVID as it is with lower socioeconomic groups as well. So we don't have that data to hand, but our assumption is it will likely replicate what we see in other vaccination programs. So I know there's a lot of work across the Integrated Care Partnership, the vaccination group, looking at how we can actually support those that maybe are hesitant, and how we can break down some of those myths that we need to overcome. So once that data does come about, we're happy to share that, but at the moment we don't have that to hand.
Thank you.
Andrew Sharp.
On that very thing, I just wanted to highlight to everybody, there's an online webinar that Community United and I think Public Health are doing on the 4th of Feb at 6:30 to talk about COVID vaccinations. sort of aimed at the ethnically diverse communities and minorities, but also I think for anyone to join in who's got sort of general vaccination questions. Similar things have been done in Reading and Woking, and I think the more information we can get to the public, the sort of minimise confusion and concern and misinformation, the better. So I'd urge everyone to sort of, you know, take part or look to see whether or not we have to repeat that at other times to ensure the vaccination programme gets taken up as well as we'd like.
Thank you, Andy. Andy Sharp suggested that we also defer the ICS or ICP, I'm sorry, update. Is there anything else you want to add, Andy?
Thank you, Howard. Nothing to add other than to say there are 6 programmes of work within the ICP. So this builds on the update that I gave at a previous meeting around the Joint Commissioning Board. So what I'm going to propose to do is that I'll bring a report giving the headlines of where we're at with the 6 programmes to the next meeting. And then the board can decide which of those programmes I'd like to spotlight on in the future, and we'll do them based on the board's priority, if that's okay.
Thank you. That brings on the member questions, which is from Councillor Vickers. As ever, Councillor Vickers, on your supplementary, can it just be relating to the response rather than creating a new issue? And I'm going to ask Matt Pearce to respond to this one.
Thanks, Chair. So yeah, Councillor Vickers. So I think you'd be aware that the council and its partners are aware of both the direct and indirect negative impacts from the pandemic to our health and wellbeing. And you might recall that the Public Health and Wellbeing team, we produced a life course infographic last year, right at the beginning of the pandemic, to try and highlight these impacts and to make people aware in terms of where there might be consequences to our health. At a recent ICP prevention board, we agreed that actually we would revisit this infographic and look at the potential indicators to monitor change over time. And I'm also aware that the council's recovery strategy and its delivery plan is also being developed that will look to incorporate key data that the council can look at to further understand, monitor and mitigate the impacts of the pandemic. And we'll be more than happy to bring that back to this board, because I think that has to be a core piece of work for the board to take place, particularly in terms of the conversations we've had around the health and wellbeing strategy. And I just wanted to make the point, obviously, with regards to non-accidental injuries, we have sadly seen an increase in the numbers throughout 2020, but I know that the Berkshire West Children's Safeguarding Partnership and the ICP Children's Programme Board continue to monitor this issue closely and working to keep children safe as possible.
Your supplementary, Councillor Vickers?
Not really, no. Thank you. It's good to hear that we'll be getting a report about what's happening to a future meeting, and I look forward to that. Thank you.
Can I ask members to note the dates of the future meetings which are on the agenda? We're hoping that we might get back to a normal public system in not too far distant future. Does anyone have any other business? In that case, I'll thank you for everyone for attending, and particularly members of the public, and I'll close this meeting.
I will confirm when the live stream has closed.
Thank you.
Well done all.
Thanks, Howard.
Thanks,
Good
everyone.
night. Good meeting.
Closed.